following on the PowerPoints. I don't know if I know I uploaded them, and I know that what I uploaded is correct, but the order of the slides when I was studying it, because I would study before I teach, the order seemed a little off, so I switched where all of the list of blood vessels were. I kind of moved that towards the end, so if you're rolling along with the slides with me, it'll skip ahead like 20 slides, but then we'll go back. Just letting you know that they're all there. I just changed the order to make it more logical and make it flow better. I don't know if I had 2 copies of it or what, but I usually teach the location last. So, and just so you know that they're not different, it's just I moved it, changed the order. Okay. All right. So we are in chapter 19. This continues on. Chapter 17 was the blood. Chapter 18 was the anatomy of the heart. And so chapter 19 is the blood vessels. So the whole thing collectively is our cardiovascular system. When we talk about blood vessels, we've already mentioned arteries and veins. Arteries are responsible for carrying blood away from the heart. Veins carry blood towards the heart. That's the only staple that you can truly stick to. You can't stick to red and blue, and we've talked about that before. Capillaries, we've mentioned, but haven't kind of put them in sync with the blood vessels. Capillaries are the very smallest of the blood vessels, and they are exactly the diameter of one red blood cell, which we have discussed. And they're found deep in our tissue where gas exchange needs to occur. So where oxygen and carbon dioxide are exchanged is where you're going to find capillaries. Okay, so you'll see that pattern as we kind of continue through. Here I have, this is a microscope slide that has both an artery and a vein. The things that I truly want you to be able to point out on these, and as we get through this chapter, you'll hear me reiterate multiple times. The open area is always called the lumen. And I don't think we've discussed that in O2, but no one we mentioned it. This open area, like the tunnel, is the lumen. So lumen is just that open area where stuff can flow through. But you can clearly see the difference in the lumen when comparing an artery and a vein. You can also see some clear distinction between the thickness of an artery versus the thickness of a vein. An artery has a whole lot more muscle because an artery is going to push blood away. And there's a pump working with the arteries, and that pump is your heart. So your heart is what is propelling blood through your arteries. But once that blood makes it to your tissue where the capillary is and gas exchange occurs, there's no pump in your toes or in your legs that sends blood back to your heart. We have to mechanically move in order for blood to come back. And that's why there's not a lot of muscle here, because there's no pumping mechanism for veins. Veins rely on our movement, our respiratory movement, our posture, us walking around, us stretching, all of that in order for blood to get back. So you can see a marked difference in the amount of muscle tissue there. The veins, because they have a much larger lumen, can accommodate more blood. So at any given time, you have a whole lot more blood in your veins than you do in your arteries, because as soon as it hits your arteries, your heart pumps it to its destination, and it may sit there or pull there for a while. So the goal is that as long as you keep moving, that you're adequately propelling blood back to your heart so that it can be cycled back. So some key distinctions between the arteries and the veins, and I'll bring this up again. I think we have this slide in here again, and it'll also be in your lab to discuss the differences. Okay, so when we look at the structure of a blood vessel, I already mentioned what the lumen was, that open space. There are 3 layers in arteries and veins, and if you've been with me for these few chapters, it seems like everything has 3 layers. You have an outer layer, an inner layer, and then a middle layer. Okay, now how we name them usually tells us where it is. So if it's cardio this, then we know that it's the heart. Okay, if it's myo something, we know that it is muscle. So tunica in this case just tells us it's the layer. So we have the tunica intima, media, and externa. And just pulling common sense on that, I would hope that you could figure out which one was on the outside, which one was in the middle, and which one was on the inside. Okay, so the layers, the intima would be the inside, media would be middle, and externa would be on the outside. The capillaries are different from both arteries and veins. They just have an endothelial lining. Do you remember what the endothelium was? Endothelium. It's the inside of the vessel. So it's just one layer, one cell thick, and that's so that diffusion can occur, so that stuff can go in and out. So the capillaries are extremely vulnerable to pressure changes and all of that, and we're going to discuss that because they're just They just have one layer, one lining. Here, it's showing you distinguishing characteristics between arteries and veins. So you can see the difference in the thickness. Of course, you have the lumen, the large lumen versus the smaller lumen. The layer of muscle, you can see the difference, and the muscular layer. Okay, here it has red for arteries and it has blue for veins. Remember, all we can truly say is that arteries carry away and blood carries towards. But the red and blue indicate that that's either oxygen rich or oxygen poor. Is your blood ever blue? No, it is never blue. Okay, here, and we're going to bring this up here in a minute, you can see that on the external layer, on the outside layer of each of the arteries and veins, there's red, blue, and yellow. What do red, blue, and yellow tell us? What does yellow tell us? Nerves. Red, oxygen rich, oxygen poor. So, just like the heart, the blood vessels themselves don't use the blood that they're transporting. They have, remember for the heart we had coronary vessels that specifically served the heart. So the heart pumped all the blood, but we had vessels that gave the heart its own blood. So the blood that the heart was pumping wasn't used by the heart. It had to go through other vessels, those coronary vessels. We're going to use the term vasa vasorum, and it'll come up in the notes and I'll show you. But that's what this is. These are the vessels and the nerves that actually serve that tissue and keep it nice and healthy. Okay? So you have your own arteries, veins, and nerves that are actually serving those individual arteries and veins themselves. This here is going to be called a couple things. Ultimately, this is called a capillary bed. This is where capillaries come together. You should be able to see here is oxygen rich. Then at this point, it's dropping off the oxygen and picking up carbon dioxide, so now it becomes oxygen poor, and it goes back to the heart through the veins. So you can see the color change happening there. Okay? This is considered a capillary bed. If it's just arteries or veins by themselves, we're going to end up calling those anastomoses, and that's also going to be in the notes, so I'd like to get that right now. But you're going to see this where we have a bunch of these vessels together. The purpose of having a bunch of them together is it depends on how much blood flow you need to that area. So if you're digesting food, we need a whole lot of blood flow to your abdomen. But if you're not digesting food, we only need a little bit of blood flow. So we'll shut off all these collateral vessels and we'll just use the main one. Because if you're not digesting, we don't need that much there. Okay? Your skeletal muscles are the same way. If you're not using them, if you're resting, you don't need a whole lot of blood flow through them. But if you're running, you're exercising, you do need more blood flow. So this allows us to change the amount of blood that makes its way to that tissue. Okay, so you'll see that, we'll reference that a few more times. One more thing I want to point out on the vein that the artery does not have is we have these valves. These valves prevent backflow. So once blood makes it, because remember there's no pumping system on the vein. So once the blood makes it on its way back, it makes it to like this area in my thigh, and say I stop moving, it doesn't just drop back down to my toes. It sits there. And it waits for me to move again before it pushes it back up. We're going to end up calling that muscular milking. Your muscles will milk your blood back to your heart for venous circulation. So those valves allow it to go a certain extent and then stop. And it prevents the backflow. Now, when you talk about collapsed valves, that means that blood is able to flow back and it allows pooling, and a lot of times we can see that with ruptured vessels. The good thing about that is a lot of these veins you can remove because there's collateral vessels that can carry out that same thing. So when it becomes damaged, or you can leave it and it just has an ugly appearance. Okay, last thing for this slide is the capillary. The structure of a capillary is, again, much different than both the artery and the vein. You can see it's just one cell thick all the way around, and this allows for diffusion. So oxygen will go from inside to out into the tissue, and carbon dioxide will go from outside in the tissue to inside the blood so it can be carried back to the heart. So we want our capillaries to be super tiny and super thin in order to allow for the exchange of gases, and that's carbon dioxide and oxygen. Any questions right here on structure? A lot of what I said is going to be brought up in the words. I just, again, like to use the diagrams. Yes, sir?
Valves only in veins?
That is correct. Valves are only located in veins. There is no need for valves in the arteries that are going away because there's the heart that's actually pumping it and moving it away. Good question. Yes, sir. Additional questions? Okay. So the intima, which is the inside layer, so tunica again is just telling us it's the layer. It's composed of endothelial tissue. We've discussed this term, we've referenced it before, but endo tells us it's on the inside and thelium tells us it's what type of tissue. Epithelial tissue, which means it has the ability to regenerate. So anything that's exposed to the environment is going to be lined in epithelial tissue. It is continuous with the endocardium. Where's the endocardium? It's the inside of the heart. Yes, it's the inside of the heart. The subendothelial layer. So the endothelium is where the blood is passing through. The subendothelial layer would be right outside it. The subendothelial layer has vessels that are larger. So these vessels are serving that. That's what we're going to end up calling the vasa vasorum. And I'll show you what we're discussing here as we continue, and I'll show you another diagram. The tunica media. The tunica media, in every situation, the middle layer is always composed of some type of muscle. Okay, the middle layer usually has some type of muscle. So in this case, is it going to be skeletal, cardiac, or smooth muscle if I'm inside a blood vessel? It's going to be smooth muscle. Not only does it say it up there, but if skeletal muscle is located where? Skeletal muscle is attached to your bones. Cardiac muscle is only found in your heart. So if it's not attached to your bones, or specifically your heart, then it has to be smooth. Okay? So the tunica media, or the middle layer of all your vessels, is composed of smooth muscle. It mentions that it allows for vasoconstriction and vasodilation. Vaso is very general. It's telling you it has to deal with the vessel. But what is constriction and dilation referring to? Okay, if it's constricting, it's getting smaller, and if it's dilating, it's getting bigger. Now we can put a term to the its. What is getting smaller and what is getting bigger in response to constriction and dilation? Not the vessel. The lumen. We're referencing the lumen. Now, yes, the muscles and all of that are changing, yes, but we're specifically talking about the lumen, how much blood flow is allowed through it. When it constricts, it reduces the amount of blood flow, and when it dilates, it increases it. Yeah. Okay, good deal. So, of course, that influences blood flow and blood pressure. The external layer has the vasa vasorum. The vasa vasorum is that key term I was mentioning earlier that references the vessels that actually serve that tissue. And you're going to see this come up a couple times. Okay, so it's nourishing that external layer. It also mentions here that the tunica externa has nerve fibers, which we know, but lymphatic vessels. This is the second time we've seen this, but we're going to see it hardcore today because we're going to bring in the lymphatic system. Lymphatics are going to be associated with our immune system. Lymphatics are going to be associated with our immune system. And I'm saying that with like air quotes because we don't technically have a structural immune system. The lymphatics are vessels that help pick up things that perhaps shouldn't be there. So we'll come back to that. But lymphatics are always represented in green. So we have nerves in yellow, oxygen rich in red, blue is oxygen poor, and lymphatics will be green. As far as blood vessels, there's no specific length that a blood vessel has to be. There's no specific diameter that it has to have. You'll notice, generally speaking, the closer they are to the heart, the larger the vessel. The further away they are, the smaller the vessel. Okay, within tissues, we expect to see really small vessels, but as it's carrying towards that tissue, we expect to see larger vessels. In my head, I imagine it as like the roadway. The aorta would be like I-35. Okay, just that main, and then we have a lot of branches that go into the small neighborhoods. So you have your service roads, and then it goes on, and then to small neighborhoods, which would be examples of capillaries. So it just starts larger, and then it gets smaller the further away you get from the heart. Okay, and the end of this chapter does kind of go through, or the way I structured it now, goes through all the different vessels. I like this diagram because it gives me a lot of good information. First of all, it shows your heart as being a box. No big deal. Okay, because if I were to draw it, I would just draw a heart. I wouldn't actually draw the structure of the heart. But here, you can see that the heart carries blood away. And of course, this is happening on both sides. This is just a teaching diagram. It's carrying blood away, but we have different arteries. The very first classification of arteries is considered elastic arteries. If you heard the term elastic arteries, what would you think, what capacity do you think they would have? They're elastic arteries. They're stretchy. It makes sense that we would have elastic arteries right next to the main pumping system because as soon as blood is coming out of the heart, it's coming with such great force, those arteries need to be able to stretch. So our first group of arteries there, those largest ones, are going to be considered elastic arteries. Then as you get a little bit further, and you can clearly see that they're starting to get a little bit thinner because they're getting further away from the heart, we have muscular arteries. What characteristic do you think that they have? There's a lot of muscle tissue there. And that's so that once the blood gets that way, that far, it can continue propelling it. So there's a lot of muscle there to continue with that pulsing action. You get a little bit further, and then we have what we call arterioles. Arterioles are very small arteries, and those arterioles will then branch into what we call the terminal arteriole, and then into our capillaries. Okay, and so we'll discuss that as we get a little bit further. So we go from large to small. Then, once gas exchanging, real quick, let me point these out here. We have sphincters. These sphincters will allow for blood to increase its flow or decrease its flow. If I need that vessel, that sphincter will relax and allow blood to go through. If I don't need that vessel, that sphincter will contract or constrict and prevent blood from going through there. So let's say here I just have my main vessel here. Okay, and then it's dropping off oxygen, it's picking up carbon dioxide, and now we're on our way back to the heart. We have elastic, muscular, and then arterioles when we talk about arteries. On our way back with the veins, we have venules, and then we have small veins and large veins. What do you think the difference is? Their size. Okay, so you have venules, and then you have small veins and large veins. And you can clearly see that there's a lot of difference in the size here. These small veins are a lot smaller, and then these large veins are a lot larger. They're capacitance vessels. Again, that's where the majority of your blood is. Right now, the majority of your blood is sitting in a vein. And as you breathe, you're pumping a lot of it back, but not the stuff that's in your toes. So then you'll start to fidget, or you'll start to wiggle your feet or kind of move your toes, and as your foot falls asleep, you'll start to contract muscles so that blood makes its way back. That's your body's way of signaling it. Okay, and here, when you look at their names, we call it the pre-capillary sphincter, post-capillary. So pre means before, post means after, okay? Then it's on its way back. Here I have green. What is green representing again? Lymphatics, which is the next chapter we're going to cover today. But lymphatics are carrying anything that can't be in the blood immediately. It'll eventually make its way back to the blood, but not immediately. And look what they run along with. Do they run with the arteries or the veins? The veins. Lymphatics will run the same course as the veins. They're again going to have very similar characteristics. There's going to be valves, and there's not going to be any type of pumping mechanism. So they're going to, again, rely on your movement. So the lymphatics run alongside with the veins. Arteries have a pumping mechanism. Veins don't. They rely on you moving, and we'll get to that. This is a really good diagram. Again, we go from elastic arteries to muscular arteries, then to arterioles, which are kind of the smallest, then to our capillaries. Then we have the post-capillaries, which are the smaller here. Then we go to our venules, small veins, and large veins. Here would be where those valves are. And you can kind of see those prominent areas where valves are, where it's kind of pulling that blood. Questions on any of this stuff right here, structure-wise? Okay, so it's going to put all of what I just said in words. So we're going to start with our arteries and our elastic arteries. As we already mentioned, they're kind of elastic. They allow for that stretching so that when blood is propelled through, they can expand and recoil as blood is ejected from the heart. Okay. When we go to muscular, it mentions that those are distal to elastic. What does distal mean again? A little bit further away, right, away from the point of reference. So distal from the elastic would be a little bit further down. Okay? They have a thick tunica media. The middle layer is always going to be muscle, and in this case smooth muscle. They're active in vasoconstriction. What's vasoconstriction? Constricting. So elastic, they allow for the elastic, the stretch and recoil, and down to the muscular where I'm continuously pushing it. When you talk about pulsatile action or feeling your pulse, that's this that you're feeling right here. Okay, and of course we're going to talk about pulse in this chapter as well. Then we go to arterioles, which are the smallest of those arteries. Okay, and they eventually lead to capillaries. As we get to this destination, we are further away from the heart, so our pressure is decreased. We want our pressure to be low because we're about to hit our capillaries. When we hit our capillaries, remember they're really vulnerable. And high pressure will rupture a capillary. Okay, so we want this to kind of slow down. So as these lumen get smaller and smaller, the pressure will decrease. And we'll discuss that when we talk about blood pressure. Here you can see the difference in the anatomy, just looking at the lumen there, the muscular layer, some things just to consider when you're looking at those vessels. Now, are you going to have to look at a vessel and say, oh, that's an arteriole? The answer is no. But not right in this class, at least. But I do want you to start to kind of put that stuff in your brain because it will help put puzzle pieces together as we make it a little bit further. It also tells you here as far as the composition of each. It compares, even though they're all arteries are carrying blood away from the heart, they're not equally composed, especially when we talk about the muscular layer. The muscular arteries clearly have more muscle than the elastic or the arterioles. The capillaries, again, are very, very small, and they're the diameter of a single RBC, which is a red blood cell. And we've mentioned that before. They're not composed of all three layers. They just have the intima layer, which is the endothelium. Okay, so the walls are the tunica intima. They're super small, which allows for them to facilitate gas exchange, for allowing oxygen and carbon dioxide to be exchanged back and forth. It does mention, though, here that they are reinforced by parasites, but not like parasites that suck your blood or that live off of you. These are a type of cell that when we talk about peri has always been on the outside of things. So this is just kind of reinforcing the external structure of that vessel. Okay, it could be continuous and it might be fenestrated, but we'll get there. And as far as these are just helping to stabilize that vessel. When we talk about capillaries, where you're going to find capillaries, pretty much anywhere that oxygen is needed. But when we talk about a tissue being avascular, we say it has no blood flow. So what are examples of tissue that is avascular? Things that we've... avascular means they don't have blood. So what are some examples? Anywhere. Okay, cornea is avascular, so we're going to have capillaries there. No. What about your cartilages? No. Any type of tissue that we said, hey, that's avascular, has no capillaries, no blood vessels. Your ligaments, no capillaries. Okay? Remember, if there's no blood flow, it's really difficult for it to repair itself or regenerate. Yes. Okay, so it mentions that you're going to find capillaries in all tissues except for the cartilages, epithelia, cornea, and lens of the eye. When we say epithelia, what are we talking about? The skin. And our skin doesn't have its own blood vessels. How does so our skin is technically, it's dry, for sure, but it's dead. It's completely dead. We even looked at, when we studied the integumentary system, that the blood flow decreased the further away from the dermis you were, because the dermis is where your blood vessels were found. Okay? We have three classifications of capillaries: continuous, fenestrated, and sinusoid. And I would pull the logical card on you, but I want to make sure you understand the terms before I do that. So continuous capillaries are going to be capillaries that are continually lined. It mentions that they allow for, they have tight junctions, but they only allow for certain fluids or electrolyte, certain things to pass through. So they're what we call semi-permeable. Let me show you what a continuous capillary looks like. So we have the capillary, we have these clefts where things are going to come out, but it's surrounded by a connective tissue layer that's kind of controlling what enters and leaves. Okay, we don't want a bunch entering and leaving. Here it also shows you We have the sites that are reinforcing it, the pericytes, helping to reinforce that tissue. You can clearly see that these are all healthy cells because they have nuclei, so they're living. You can also see that this is a capillary because the red blood cells fitting through there just perfectly in the diameter of one red blood cell. Fenestrated capillaries. Fenestrated capillaries are going to be in places where I need a little bit more than the basics to be able to go in and out. Okay? So fenestrated means that there's some gaps in it, a little bit of extra gappage so that more can flow out. It mentions that these function in absorption or filtrate formation, in places where I need things absorbed or I need to filter things out. Main areas where absorption is going to take place, small intestines. Main areas where filtering is going to take place, the kidneys. Okay? So we're going to see these fenestrated capillaries there. Let me kind of show you what they look like. You can see that they have the normal clefts, but they have additional holes. So fenestrations, so openings where things can be forced through. So here again is fenestrated. Let me show you again. Continuous. You can't see those holes or those gaps there. So these are quite more permeable than the continuous capillaries, and not located in the same locations because they carry out different functions. Then the last ones are sinusoid capillaries. I don't know if any of you remember when we talked about sinuses, what they were, because we mentioned them in the skull, but a sinus is just like an opening. We have sinuses in our skull, they lighten our skull, but they're just really large openings. So if I have sinusoid capillaries, these are capillaries that probably have really large openings. And I'm going to find them in places where really large things need to go through. Okay, so it mentions that. We find these only in the liver, bone marrow, spleen, and adrenal medulla. Bone marrow, liver, spleen. These are our blood vessels. These are where we're going to have a high blood flow. Those are not blood vessels themselves. I didn't need to say that. But they have macrophages. Macrophages are a type of blood cell that will engulf things that aren't supposed to be there. So they'll leave those vessels, engulf the bad stuff, and then bring it back in. So we need to have large holes where they can go back and forth. Okay? So look at the difference in the anatomy of those. Okay? Spleen is filtering out old red blood cells. I keep saying vessels. Old red blood cells, helping to filter out a lot of bacteria or any other antigens. So we have a lot of filtering going on here. Again, only located in certain areas where their function, or where this structure benefits that function. Okay, capillary beds. So when I showed you the artery and the vein diagram, and then I said this in the area could be called a capillary bed or anastomoses, which we haven't got to anastomoses yet. But a capillary bed is where all the capillaries, the arterioles, will branch into the oxygen-rich capillaries, and the vein, we have our oxygen-poor capillaries that will then go to our venule. Okay? Some terms that you'll see here. Terminal arteriole. This is the very end of the artery path, and this will lead to the main capillary, the meta-arteriole. The thoroughfare channel is if it was just that one-way I-35. Okay? And I'll show you a diagram of that. Whenever we're done with the gas exchange and that thoroughfare channel, we have a post-capillary venule, which will take that blood back to the venous circulation, which will carry it back to our heart. Okay? Let me show you a diagram real quick, and then I'll come back. So here we have our terminal arteriole, and here you have your main passageway. And here you have your venule, your post-capillary venule. Then, in the event that this tissue does not need a whole lot of blood flow, which we're going to end up calling perfusion in a few slides, then we close all these sphincters so that the blood just travels on that main highway. In the event that the tissue does need a lot of blood flow, we open those sphincters and we allow for that perfusion in that tissue. Okay, so that's going to happen depending on what activity we're doing and where those vessels are located. So the previous slides are going to talk about the terms true capillaries, so you can see, and I'll come back to this to show you, but true capillary makes direct attachment. So these are what we reference as capillary beds, and the blood flow, the perfusion, determines whether or not those sphincters are open and shut. A vascular shunt is those sphincters that I was referencing. Okay, so it determines whether we're going to open it or close it, depending on what blood flow is necessary. True capillaries branch off the meta-arterial, and then they're going to go right back to that venule. So I'll show you what I'm talking about when I get to that picture. And run that. Precapillary sphincters are going to be what allow for that blood to go back and forth. Let me show you here. The vascular shunt is showing us that it's going into that meta-arterial. The actual sphincters are the names of the structures that allow for the changing in that blood vessel. So they may go through the true capillaries or be shunt. And so those two should be connected, not necessarily separated from each other. I apologize for that. Okay, here again we have our true capillaries. So you see they're going and connecting back and forth. We have a lot of collateral vessels here as well. Meta-arterial going straight through in the event that we don't need a lot of blood perfusion. We have all those sphincters open. It's not shunt in that sense if all of those sphincters are open and the blood is getting through from the arteries to the veins. Questions on capillary beds. Okay, now we're coming back. So we let gas exchange occur real quick. Oxygen rich, oxygen poor. This area where it's kind of faded is where the gas exchange is physically occurring. So oxygen's being dropped off and carbon dioxide is being picked up. Okay? We're coming back. We start with our smallest veins, which are called venules, and they're lined, very small muscles, if any, muscular layer, and mostly endothelial tissue. So on its way back. We will also talk about the fact that they're very porous and they have the valves. As veins or venules converge, we start to make our smaller veins. It mentions that they have the tunica media is not large, so it does not have a lot of muscle there, but the tunica externa is full of collagen and elastic. Again, what is elastic going to tell us is necessary in those vessels? They're going to stretch, which is where we come to the term capacitance vessels. Capacitance vessels means that these are able to hold a whole lot of blood. The only thing that's going to change the amount of blood that is in those vessels is you moving. So you sitting still allows for blood to back up in those vessels. At any given time, about 65% of your blood will be located in your veins. Here is a nice little pie chart that shows you the distribution of that. So here in your veins versus all of your other vessels in your body, and of course in your heart, not necessarily a vessel, but the majority of your blood at any given time is going to be found in your veins. As it's going back, the veins have valves that prevent backflow of that blood. We're going to see a lot of valves in areas where once it gets, we stop moving, we don't want it to go all the way back down. So it mentions you have a lot of valves abundant in the veins of the limbs, so in your arms and legs. These are also in areas as you get older and have geriatric patients where you get varicose veins and collapsed valves. So you can see that on the surface because they push towards the surface. A sinus. These sinuses are areas where blood will pool. We've just said that a sinus is just a larger opening, so they will pool here. We have areas where they collect. We mentioned the coronary sinus in the heart, which is what dumps right back into the right atrium. We mentioned that the last lecture. Okay, so you have sinuses in your heart. You have them in other places. It also mentions them in your brain, and which can lead to, well, we'll get to those conditions later. Here we have the capillary. Again, it's just one layer thick. We have some connective tissue to reinforce it. Here we have the venules, the smallest of the veins. You can still see that there's a large lumen, but there's barely any tissue surrounding that as far as anatomy is concerned. Here, in our largest veins, we still don't have as much muscle as we even have in our medium-sized arteries. So you can see again the distribution of the types of tissues for each type, or each division of veins. So these are all veins carrying oxygen, it doesn't necessarily have to be oxygen flow, but carrying blood towards the heart. The only distinction between arteries and veins is the direction they carry blood. We can't just go with red and blue. So this is the diagram we had at the beginning that I showed you, and I said let's discuss, let me point out some things. So now you can kind of see differences in the arteries and the veins. Hopefully, at least you can kind of explain them to yourself as well. Why veins, have a larger lumen and less muscle tissue, and in arteries, the opposite. So anastomoses. Anastomoses is where a lot of these vessels, smaller vessels, come together. There's a lot of reasons for anastomoses. The two most important. I need collateral vessels for something. Like one vessel is damaged, so I can use another vessel instead, and that individual can maintain homeostasis. The other purpose of an anastomoses would be to increase blood perfusion to an area. So we're going to talk about, like, when you exercise, you need an increase in blood flow, and so we need vessels to be able to accommodate that increase in blood flow. Okay? So arterial anastomoses are going to be located where? In the arteries. Where do you think venous anastomoses are going to be? Veins. Yeah. Good. Okay? So blood flow. When we talk about how blood flows, we talk about it going through the vessel. How do we measure it in milliliters per minute, unless we're talking about pressure? So we're just talking about blood flow right now. It's the equivalent to cardiac output, which we discussed in a previous lecture. It's relatively constant when you're at rest. What type of things would increase your blood flow? Exercise. Getting up and doing something. I mean, not trying to say obvious things, but obvious things would cause you to increase your blood flow. Your blood flow to your organs changes based on what you're doing. If you ate before you came to class, and you're sitting down right now, the blood flow to your intestines is very high because you're digesting that food. Okay? If you didn't eat and you haven't eaten since breakfast, the blood flow to your intestines is not high because there's no need for it to be digesting anything right now because it's already past that. Okay? It just depends on what you're doing and what your needs are at that time. So blood flow is the movement of blood through your vessels or through your body, measured in milliliters per minute. Blood pressure is the force that moves that blood through your heart and vessels. It's expressed in millimeters of mercury. So mmHg is millimeters of mercury. Okay? And when we measure your blood pressure, we talk about systolic over diastolic, which we mentioned in the previous lecture as well. Systolic is the contraction, and diastolic is the relaxation, and we're going to discuss those. We also talk about your pulse pressure. Okay? The goal of blood pressure is just to keep blood moving through your vessels, not just pooling. When blood pressure stops or blood pressure decreases, what happens to the blood flow? It decreases, and then you eventually, if that continues to decrease, then you eventually expire. Okay? When you're talking about blood pressure, one of the main things to consider is the resistance. How hard does your heart have to work in order to propel blood throughout your body? So resistance is how we classify the distance or the lumen, the diameter of the lumen. Resistance is how we discuss how hard your heart has to work. Three things are important when we talk about resistance. Your blood viscosity. The thinner your blood, the easier it is to pump. The thicker your blood, the harder it is to pump. So that's being hydrated versus dehydrated. Total blood vessel length. If your blood vessel is really short, then it's probably not difficult to pump blood through. But if you have a blood vessel that runs from your aorta to your foot, which you do, that's a longer blood vessel. It takes more force to propagate blood through that vessel. The diameter of a vessel. The larger the diameter, the easier it is to get blood through it. The smaller the diameter, the harder. So when you're talking about resistance and blood pressure, these are things that we're discussing. One main factor of vessel diameter, especially for our elderly patients, is going to be, do they have any type of buildup in their vessels? Because their vessels might be completely dilated, but they have a whole lot of cholesterol built up in it. So that technically makes the lumen much smaller. Okay, and there's not anything that you can do muscle-wise to change that. So these are factors that we take into consideration. And I've explained these on the previous slide, but again, blood viscosity is how thick or thin your blood is. The blood vessel length, I feel like that's quite obvious how long your blood vessel is. The longer it is, the more you have to work. And the diameter of a blood vessel, if the lumen is large, it's easier to pump blood. If it's smaller, it's more difficult to pump blood. And it might not just be regular changes constriction and dilation. It may be that you have some type of buildup in those vessels. When we talk about blood pressure, your blood pressure is going to be the highest here. Why will it be the highest here? Yeah, your heart. Your heart is that main pump. So your blood pressure is going to be the highest here. And then the aorta in that vessel, that's your largest vessel, largest artery, your blood pressure is going to markedly decrease by the time it makes it to your distal appendages. But then it has to make its way back. By the time it makes its way back all the way to your heart, your blood pressure should be 0. So it goes from being really, really powerful to absolutely nothing. And the only thing that's kind of bringing it back, and I had to learn this, like, think my way, because if the blood pressure is 0, there's nothing moving it. So how does it actually get back to your heart? The lazy river type flow. Like you're just in the lazy river, and it just, because of that current, it's what's carrying it back. So even though the pressure is 0, because there's that steady current, it's just kind of floating its way back. And it's getting there consistently. Thank goodness, for sure. I love this diagram because it shows you the difference in the pressure, starting with the aorta, which is your largest vessel, then going through your arteries, which that would include your elastic, and your muscular arteries to your arterioles, which are your smallest arteries. Capillaries, where gas exchange occurs, so you can see that there's a huge difference in that pressure. Then it's coming through our venules, our smallest veins, then our veins, small and large, and then all the way back to the vena cava. The vena cava is where it enters the right atrium. We have a superior and an inferior vena cava, and this is where it goes right back to your heart. So this is leaving the heart, and this is all the way back to the heart. Good diagram. Okay, arterial blood pressure, we expect for that to be the highest, because it's coming straight from the heart. We know that our arteries have some type of elasticity, okay? And whatever's being pumped through our arteries is being forced because the heart is a pumping mechanism. This is what generates our pulse. So we mentioned that our blood pressure near the heart is pulsatile. So if it's near a large vessel, you'll be able to feel a pulse. Areas where you can feel pulse, real quick. Let me show you that. Okay, I thought it was right the next slide, sorry. Systolic pressure is the pressure of contraction. So systole. This should be average. Our textbook numbers are 120. Should be around 120. When we talk about diastolic, that's where there's the lowest amount of pressure. But this is only being measured in the aorta. You don't measure this in a vein. It doesn't necessarily have to be the aorta, but usually it is the aorta that we're measuring. The pulse pressure is the difference between the two. So for example, if my systolic pressure was 120 millimeters of mercury, my diastolic pressure was 80. My pulse pressure would be 120 minus 80, which would be 40. Okay? So that's how you would configure that. Yes?
I have a question. So like whenever I go to get like your blood pressure taken, if you cross your legs, why does it affect your blood pressure?
Great question. So when you cross your legs or bend your arms or pull your fists, you increase the resistance. So when you increase resistance, it increases your blood pressure. So whenever they don't, a lot of people don't even like it if you talk while they're taking your blood pressure. Because when you talk, you're forcing air out, so it's increasing the pressure in your abdomen, which could have menial effects on your blood pressure. But that's a great question. So when you cross your legs, you're increasing the resistance, so your heart immediately responds. Says
Every time I get my blood pressure taken, I
immediately cross your legs. Yes, that is exactly why. Good question. Good question. Mean arterial pressure. So this is used if you have ever, I'm sure at some point you've seen somebody in the hospital or you've been in the hospital, but you know those monitors that they have? There they have your blood pressure, they have your pulse, and they have your MAP, which is your mean arterial pressure. These are all numbers that they use to watch your vital signs and make sure that your pulse ox level is there too. They're measuring to make sure you're good, healthy, and alive. Okay? But your mean arterial pressure is the pressure that it's taking to get to all of your tissues. The way you calculate this, and you're not going to have to calculate it, but it's your diastolic pressure, which is that bottom pressure. So in our example in the previous slide, so let's say it's 80. Okay? And 1/3 your pulse pressure. So if my pulse, using the numbers on the previous slide, was 40, roughly 1/3 of that is like, it's not a perfect number, but around 13/14-ish. So you have 80 plus 14 or 13, and that would give you your mean arterial pressure. So, and it's showing you here, the 120/80 is your blood pressure. Your mean arterial pressure would be the bottom number, 80, plus 1/3 of the difference between these two, which would be 40. 1/3 of 40 is approximately, I'm going to use 13 now because I see that the answer right there is 93. So 80 plus 13 would be 93. So mean arterial pressure. And that's just the mean pressure of all of your arteries. Okay, so that's your map. It mentions that as we get to our capillaries, we expect our blood pressure to decrease. And that's because the higher the pressure, the more vulnerable those vessels are to damage. So remember, gas exchange is taking place here. Our individual red blood cells are going in single file, one at a time, dropping off oxygen and picking up carbon dioxide. So we want to kind of keep the flow, but we want it to be at a pace where we can actually drop off oxygen, pick up carbon dioxide, and do it in an effective and efficient manner. So we want there to be some pressure, but we want it to be minimal pressure. So it mentions the changes in pressure there, textbook-wise, because these vessels are permeable, and so we want it to be lower pressure. When we get back to the veins, our blood pressure continues to decrease. I mean, it's decreased since we've left the heart. But as we continue to make its way back, the resistance is ridiculous because it's already made its way down. Now it's on its way back with no pumping mechanism. So pressure levels are really low. This is you after you've been studying for a really long time. You're not going to just get really low. Okay, and somebody's like pushing you. You just don't want to do anything. All right? It mentions here that because there's no major pump, like the heart is for the arteries, these are the mechanisms that function to help pump blood back to the heart. So our venous pump, if you will. The muscular pump, so this is just the contraction of your skeletal muscles, you moving. Okay? Every single time you move, those muscles contract and it squeezes blood back up, and it makes its way to a certain extent, and that when that muscle relaxes, that valve prevents it from going any lower. The respiratory pump. This is you breathing. Just you breathing alone uses your external intercostal muscles and internal intercostal muscles, your abdominal muscles, okay? Even talking does that same thing. So you're increasing the blood back to your heart. Now, if you continue to talk, and you don't breathe, you get lightheaded because you need the oxygen. But it is helping to get venous blood back to your heart. Okay, so there is a point where you have to stop and take a breath, but that allows for that milking action. The last one, this term is different than what we saw previously. We saw vasoconstriction. Now we see venoconstriction. Veno tells me this is specifically occurring where? In the veins. So the constriction of the veins. But the thing to keep in mind is, can the veins get really small? The answer is no, because they don't have a large layer of muscle. Remember, they don't have a whole lot of muscle, so it's really difficult for them to get really small. But nonetheless, these are some mechanisms that assist with getting blood back to the heart. Here is an example of the muscular pump. So it's showing you here like a muscle contracts, and it squeezes that vein, so it pushes that blood up. You can see it's opened that valve, and once that muscle relaxes, that valve will slap down and prevent the backflow so that the blood doesn't drop back down further. Maintaining blood pressure. The main things that you need to keep in mind when you're trying to maintain your blood pressure is that you have good heart health, that you're adequately hydrated, your blood vessels, and then we have our kidneys. Our kidneys do a huge job of making sure that our blood pressure is consistent. Remember that antidiuretic hormone is responsible for making sure that your blood volume is pretty constant. So if we can keep your blood volume pretty constant, we can maintain blood pressure. Okay? And this is unassisted without medications. Okay, so a lot of people have issues maintaining a homeostatic blood pressure, and that could be for a series of issues. But a lot of blood pressure problems are secondary. Do you remember what a secondary problem means? it's caused by something else. So you have a primary problem, and having blood pressure, which it's going to bring this up in a moment, that blood pressure issue is secondary. So if you would fix the primary problem, you would no longer have the blood pressure issue. Okay? So main factors influencing blood pressure: cardiac output, which we discussed in a previous lecture; peripheral resistance was this lecture, as well as blood volume. Here it's kind of showing you how sympathetic and parasympathetic activity increase or decrease blood flow. Okay? So you can read through that if you would like. Short-term blood flow can be regulated by neural or hormonal mechanisms. What is a neural mechanism? Brain. So if all of a sudden I got really scared, my brain would tell my body I needed to speed up. It would immediately increase blood flow. Fact. If I got scared right now, not only would my nervous system tell me to speed up, but I would stimulate my adrenal gland to release epinephrine and norepinephrine, which would cause the dilation of my blood vessels, increase my heart rate, increase my respiratory rate. So that would be a hormonal control. Okay? Those are pretty quick, but short term.
Why is it that you start to feel kind of like once you're scared and you know it's just no big deal, you got scared for nothing, you start feeling kind of...
Yeah, okay, because if you get scared, and we see this happen a lot in people who are anxious or suffer from anxiety, because you make yourself scared and you're not physically moving. So you're worried about something to the point where you're stimulating a sympathetic activation. But you're perhaps like in your car, or you're at a desk, or you're laying in bed, and you can't physically exert the energy to help bring that down. So you're having hormonal fluctuations at that point. And a lot of times it takes you relaxing, a forced relaxation, where you have to talk your way out of it. Breathing, just breathe in, breathe out, breathe in, and maybe even taking a short walk if that's an option to help relieve that tension. What we have instead are a lot of people building up this anxiety and not knowing how to handle it, so they take medications that keep them from releasing those normal controls, so that when they do get excited or scared, you can't do anything. You're just like, oh. And we see that, and that's actually the main complaint of people who take like mood stabilizers or anxiety medication. It's that they're starting to lose feelings for things because it doesn't distinguish between whether you're anxious or whether you need to be. So, good question there. So short-term controls are going to be neural or hormonal, but long-term regulation of blood pressure is your kidneys. So if you're having blood pressure issues, and it's been for a long time, they're going to take blood volume or blood counts to look through things, but a lot of times it's our kidneys. We don't have enough water, or our sodium levels are really high. You have a diet high in sodium. These are things that our kidneys pick up on, and it puts a lot of pressure on them, and then they increase our blood pressure in order to compensate for what it is that they're trying to fix. So I actually already discussed this, but your neural control, so your blood can tell you immediately, not your blood, your brain can tell you immediately to increase blood flow. Okay, do you remember where your cardiovascular center is? It's not your heart. It's in your medulla oblongata. Then by the respiratory center and the cardiovascular system is in the medulla oblongata. So it mentions that the medulla controls that. So immediately, if we need to increase blood flow or a respiratory rate, our medulla oblongata is going to handle that for us. But real quick, the last thing I want to mention about the medulla oblongata is the fact that it's just part of the brain stem. It's not the actual brain. So do I have to tell myself to do it? No. It's an automatic reflex. So literally sometimes, and that goes back to this conversation we were just having, you can be relaxed, and then all of a sudden you remember something that you should have done. And you can send your heart rate skyrocketing, and you're not physically moving. You're like, oh crap, I forgot to do that. And you just know the implications or the ramifications of not doing that, and that itself can speed you up. So you can do this mentally. It doesn't necessarily have to be you because this is just your reaction, okay, to whatever it is going on around you. Your vasomotor tone is where you are naturally. So this is where you are naturally. Are you a little bit high-strung, or are you a little bit, mellow? We discussed this in a previous lecture as well. Why would your blood pressure decrease? Blood pressure decreases are due to arterial vasodilation, venodilation. So what's happened in both of those cases? The vessels, the lumen has increased, or decreased cardiac output. So for whatever reason, your cardiac output has decreased. Whenever, first of all, baroreceptors. What are baroreceptors responding to? Barometers respond to pressure. So pressure sensors. And we have baroreceptors all throughout our arteries that tell us, that help send messages to our brain that say, hey, pressure is high, pressure is low, we need to regulate this and that. So baroreceptors are our pressure receptors, and we have those all throughout our vessels in our body. And it mentions here that they can quickly adapt to chronic high or low blood pressure levels. Long-term mechanisms that control blood pressure alter the blood volume, and we do that by using the kidneys. So if your blood is super thick, remember you release ADH, so you retain water to try to thin out your blood. And if your blood is really thin because you're really adequately hydrated or maybe overhydrated, you pee a lot. So ADH is not released. But that is all from your kidneys. So that's why it's mentioning that long term. Okay? And that's what that renal mechanism is that I just discussed. And this continues talking about the kidneys. But the kidneys regulate your water volume. So if your water volume is high, we pee a lot. If you're becoming dehydrated, you don't pee a lot. We're trying to retain as much water as possible to maintain our blood volume. Vital signs are signs that we use to make sure that you're alive. Your pulse is measured using the expansion and recoiling of your arteries. Radial pulse, where's radial pulse? Okay, so radial pulse is here at your wrist. When we use the radial pulse, if you have a radial pulse, that's telling us that blood is making it that far. Does that make sense? So sometimes you'll be trying to take somebody's pulse and you can't find it. Doesn't necessarily mean they're dead. Okay, they could have a really low blood pressure. It could be they might be a really in shape athlete, and so taking a radial pulse might be difficult. Doesn't mean they're dead. So a lot of times I'm like, I can't find a pulse. Now, if your patient is clearly dead or and you can't find a radial pulse, then maybe they are dead. Okay, but if you have somebody sitting here talking to you and you can't find the radial pulse, we're not like, oh my gosh, you can't find it. They're obviously alive. Okay? And where else can you take pulse if you can't find it radially? All these pressure points, which is where I was looking for just a few slides ago. But you have your radial pulse, you can take a brachial pulse, the carotid, okay, facial underneath here. A lot of times when I have my freshmen, we do a lab where we exercise around the hawk's nest. I make them, the hawk's nest. Anyways, we run around this area and then they have to take their pulse. And a lot of times they're like, I don't have a pulse. And so right here, this is the easiest place for a lot of them to take their pulse. It's going to be really high here because it's really close to their heart. So it's easy for them to feel that there. But again, you can take the femoral pulse right here inside the groin. Behind the knee, you have an artery here. If you can feel the pulse in these very distal areas, that tells us that blood is making it that far. Does that make sense? So it's awesome if you can find that and feel that, because that's showing us that those tissues are receiving that blood. When we take blood pressure, we use the oscillatory method when we're listening, using a sphygmomanometer. That's a blood pressure cuff. Why can we not just call it that? I don't know. Anyways, whenever you're taking blood pressure, and this is using the old school method. So now you can hook them up to a machine, and the machine does it, and you get this little reading, and most of the time that's what they use. But I always make my students, especially in A&P2, I'm like, we're going to learn to take blood pressure the old school way, because what if the batteries are out? And what if, they're like, that's never going to happen. It may never happen. but I do want you to know low-key how to take blood pressure. But you use the sounds and you watch the little needle and bounce back and forth. And I believe, well, I don't think we do that loud because this is a condensed semester. But when you're taking it, you're looking for the bouncing of that needle, and that's showing you that there's pulsatile pressure, and then it will stop, and then it will start again, and that's where you get your systolic and diastolic numbers. So I always want you to be able to do that. I hope it's in the lab. Surely I incorporated it. Maybe I didn't. I'm not really sure at this moment. But it's a good method for learning how to take blood pressure. That way you know how to take it. In the event that there's no batteries or electricity or all that stuff shuts down and you need to know somebody's blood pressure right now. Okay, systolic pressure is that the pressure of contraction or systole. So textbook number is 120. Diastolic is the pressure of diastole, which is that relaxation. Textbook number 80, again they're measured in millimeters of mercury. Whenever we hit that systolic, you'll see it kind of bouncing the needle, and I'm talking about when you're trying to take blood pressure. Then all of a sudden it will stop, and it will have this smooth little maneuver until it hits diastole, and then it kind of goes up a little bit, and then it goes, and then that's how you know that you've reached it. That's what it's mentioning here, and the sounds that go along with it. When you hit systole, you should hear the blood going through the vessel if you have the little stethoscope next to that vessel. And then when you no longer hear it, you know that the pressure is so low that that vessel is not pulsatile anymore. That's what it's referencing here. Your blood pressure can change at any minute. Things that could cause your blood pressure to change. You're exercising. I think that's the obvious one that we keep mentioning. But you get emotionally upset, or you're scared, or you haven't eaten in a long time and you're about to faint. Something, blood pressure can change minute to minute. Okay, so it mentions that here. Your age, we would expect, unfortunately in America, we expect your blood pressure to increase with age because people stop taking care of themselves. But we want your blood pressure to kind of get lower because you're taking care of yourself. Males versus females, there should be a difference in blood pressure. Textbook. Race, mood, posture. And when we talked about taking your blood pressure, whenever you're creating resistance, it's going to increase your blood pressure. People who tend to slouch a lot have a decreased blood pressure if you take it at that point. If you're sitting up straight, also for an extended period of time, that decreases blood pressure because it's easy blood flow. So it just really depends on what it is that you're doing, but your blood pressure can change all the time. Having high blood pressure, hypertension, that's an issue. Your hypertension could be chronic, meaning you've had it for a long time, or it might be something acute. Sometimes it's just all of a sudden your blood pressure is increased. Like if you're scared, we would expect you to have a higher blood pressure. What we don't want is you to maintain that high blood pressure for hours and hours and hours, because that tells us that it's no longer just that situation, that there's also something that's following up on that. Yes?
I don't understand how this inaccurate read if it's actually squeezing.
So what you're...
Wouldn't that make your veins smaller so then you're not getting a true read?
Great question. So the way a blood pressure cuff works is it makes it so tight that it stops blood flow. Right? And then we loosen it, and by the time that we loosen it, the first reading we get is when that pressure is hard enough that we can get it. So that would be our systolic pressure. And then it will continue to loosen until we can't feel that pulsing anymore, which means that those vessels have gone all the way back to diastole, or relaxation, and that would be my body. Great thought process. Great thoughts. Yes. So hypertension long-term is an issue. Well, remember, 120 over 80 are our textbook numbers, systole and vascular, so 140, 90 is usually when we say they're hypertensive, but that needs to be for an extended period. Pre-hypertensive means that you have a slightly elevated blood pressure, but it might not be that you're hypertensive. We see this a lot in women who are pregnant. If you're going through certain things or there's stressful things going on, you might be pre-hypertensive, but it could be transient. What does transient mean? It just kind of comes and goes. Okay, so you're not really hypertensive, but whatever situation you were in at that time, it caused your blood pressure to increase. Okay, but again, the issue is long-term, chronic increase in blood pressure, and if you're pregnant, we're super sensitive to that, because if you have a higher blood pressure, that means your oxygen levels are lower, And if your oxygen levels are low, the baby's oxygen levels are even lower. Okay, so blood pressure issues when you're pregnant are incredibly amplified. It mentions here that prolonged hypertension may eventually cause heart failure, which we see in a lot of patients, vascular diseases, renal failure, and stroke. And this is because the heart has to work harder. So the heart becomes larger, so it's because it's a muscle, and as it becomes larger, it actually becomes more inefficient at pumping blood. Okay? It also accelerates atherosclerosis. What's atherosclerosis? Yes, this is the buildup, the cholesterol buildup, the trash buildup that you find in your vessels. Okay? Here, it mentions that some people are hypertensive and there's no cause for them to be hypertensive. They are overall a healthy individual. But a lot of individuals that are hypertensive are actually secondarily hypertensive, which means, we've mentioned this just a moment ago, that they have a primary condition. If they would treat the primary condition, then the secondary condition would disappear. In fact, there is a lot of studies that show if we could get people to eat healthier, because one of the most prescribed medications right now are blood pressure medications. If we could get people to eat healthier and decrease their weight, the blood pressure prescriptions would decrease. Because if we could decrease your weight, we could cause your heart to work more efficiently, and you would no longer need those blood pressure medications. So a lot of people begin to get blood pressure medications because of weight gain. So obesity is one of those. There is a hereditary aspect. I will tell you, there's people who have come across completely healthy. They eat well, they live well, and there's just a genetic aspect that causes them to be hypertensive. Okay? That is a thing. Poor diet, age, having diabetes, stress levels, smoking, those are all factors that could lead to hypertensive conditions. We cannot if you have hypertension and we can't, like it's a primary condition, we're going to tell you we want to restrict your diet. We want to take out salt, sodium, and all of that. Cholesterol levels, we want those to be low. We want to increase your exercise. We want to lose weight. We want you to stop smoking. We basically want to change everything that you're doing. Okay? And then, of course,
Too late to learn
it is really, and that's why people are on.
Like in school, of course, they teach you eat fruit, vegetable, healthy, but the extent of it, you don't learn it until you're grown. You already like those
Oh,
foods.
yeah.
It's too late.
My sister's a perfect example. Takes her blood pressure medicine while she's smoking and drinking beer. I love her. Not a fan. Not a fan. She's like, oh, I'll exercise. You're still. You're still. So again, secondary hypertension, that's because we need to treat the underlying cause. So we've discussed that. Hypotension is the opposite. So that means that you have a low blood pressure. And for the most part, that's not a bad thing. This could mean that you're really in good shape. Okay, so it's not a big deal unless it gets so low that blood can't get to your brain or your other tissues and it causes you to faint. Now, that's an issue. But if you have a low blood pressure, you go in and it's supposed to be 120/80, but you get a 112/65, that's not that just is saying that your blood pressure is low. And there's not anything wrong with that. The only issue would be is if it couldn't get blood to the rest of your tissues. Okay? You could have transient hypotension, which is what we would reference as orthostatic. Orthostatic hypotension means that you haven't moved in a while, and then all of a sudden you move, and you get the dizziness, and you're like, oh my goodness, you're hypotensive. Well, it's just because you were staying in the same spot for a really long time. We see this again with a lot of geriatric patients that stay in the same spot, but they have to move to go to the restroom. Okay, so it takes them a little bit to get their blood pressure back up. Chronic hypotension, that it's super low for a long period of time, is usually diet related, and that can lead to different conditions. That chronic just tells you it's a long-term type thing. It doesn't necessarily mean that anything's wrong, but it could mean that something's wrong. Acute hypotension, acute tells us it happens all of a sudden, and of course it's going to use your gunshot wound and stab wound. Like for some reason, you've lost a whole lot of blood probably some traumatic event, and you need to have that blood replaced. Tissue perfusion. Tissue perfusion references how much blood is flowing through a tissue at any given time. We want tissue perfusion to equal the amount of work that that organ is doing. If it doesn't, then we have an issue. So we want to make sure that if we're bringing in a whole lot of oxygen, that our tissue is getting a whole lot of oxygen. And if we're not, that our tissue is not. And that's usually going to be associated with exactly what we're doing. So if we're breathing a whole lot, we're probably running or doing something pretty stressful in our body. We want to make sure our tissues get a whole lot of blood so that they get that oxygen. Here gives you an example. At rest, this is showing you about how much blood makes its way or circulates through these individual tissues in general, okay? But then it goes to you doing something strenuous. So here was at rest, here's strenuous. Pretty much everything increases except for, tell me what one thing stays the same. The brain. The blood flow through the brain cannot change a whole lot. We need to keep that homeostatic because the brain, remember, it doesn't have vessels specifically on it. It's working through diffusion, so we need to keep that pretty solid as far as the blood flow to the brain is concerned. To the heart, of course, if we're doing something strenuous, we would expect to see an increase in blood flow there. Skeletal muscles, if we're working out, we need more blood flow to our muscles. To our skin, why does the blood flow to our skin increase? Yep, so we can sweat. Okay, so it causes us to sweat so we can maintain homeostasis. What happens to the blood flow through our kidneys? It decreases because we don't need to pee, right? Because we're trying to maintain our blood volume. So we're going to be retaining water there. Our abdomen, why does that decrease while we're working out? We're not digesting. Okay? Same thing here with all the other aspects of your body. Your main core area is the area that we need to increase blood flow, keep the brain homeostatic. Here it's telling you that overall the blood is going to flow fastest in the aorta, or the largest vessels, and slowest in the veins. And it should be kind of midway through when we get to the capillaries. Okay, and that allows for gas exchange to occur. So you can see, and this is kind of what we've been referencing throughout this lecture, so it's not anything new that's taking place. Autoregulation. This is your body's way of auto-regulating the blood flow. How many of you tell yourself to increase your blood flow? You don't, because your body does it for you, which is why we call it auto-regulation. So it tells you that it automatically adjusts the blood flow depending on what it is that you need. So I feel like this, not saying that this is obvious, but I feel like you understand that your body's taking care of this for you. Okay? Here is showing you things that could function as vasodilators, things that could function as vasoconstrictors. So things that will allow for dilation and things that will allow for constriction. And I don't mean like things, factors is what I should probably say for that. Okay? Angiogenesis. I mentioned this one time when we talked about cancer, but it wasn't in O2, it was in O1. Angiogenesis is the formation of new blood vessels. When you form new blood vessels, it's because that tissue has communicated with your body long enough to say, hey, I'm here, and I need you to get me nutrients and oxygen. So you will form new blood vessels as you need them. So if you started working out today and you formed a lot more skeletal muscle and a lot of hypertrophy occurred, so you got larger muscles, you would need more blood vessels to increase the blood flow to that tissue so that you could continue to use those muscles effectively. You would create new blood vessels. Also, if you moved from Texas to an area where the altitude was higher, like for example Colorado, and it wasn't just that we were talking about the acclimating factor, but you are living there. You are going to generate new blood vessels so that you can increase blood flow to your tissue for gas exchange to occur. So angiogenesis is just the formation of new vessels. Okay? Overall, this is going to use that diagram that I referenced just a moment ago that showed you rest versus increased activity. So blood flow to the skeletal muscles. Blood flow to the skeletal muscles is pretty constant when you're at rest, and it increases when you're doing some type of activity. You don't have to be hardcore working out. You could be walking from your car to class, but blood flow will increase in your skeletal muscles. Okay, so it mentions that here. blood flow to the brain, you know that we want that to stay pretty constant. We don't want that to fluctuate. Okay, so blood flow to the brain, it mentions that there. We want that to stay pretty consistent so that we're dropping off oxygen, picking up carbon dioxide in the amounts that we need to with no additional pressure. Why don't we want any additional pressure? Because the brain is super vulnerable. If there's not enough pressure, you could faint, and if there's too much pressure, it could cause an edema. What's an edema? A swelling. Okay? It can cause swelling. Cerebral edema is swelling of the brain. Swelling of the brain will lead to expiration if you can't control it pretty quickly. Because your skull is not going to say, oh, the brain's swelling, let me get bigger. Your skull stays the same size, and as your brain swells, it gets crushed. So we don't want changes or fluctuations in the brain pressure.
What's the term for when the blood clot breaks off?
Thrombus.
I don't know what I was thinking.
Edema is just swelling. I understand, yes. And then embolism was whenever we talked about it, yes. So that's what I was going to say. We went from thrombus when we talked about platelets and then breaking out, causing that clot, and then it becomes an embolus, and then an embolism, yes. And we talked about cerebral and pulmonary embolisms.
Okay.
And an aneurysm is when that blood vessel ruptures. So embolism and aneurysm are different. But those are terms that usually come to mind when you start thinking about brain issues and pressure.
The brain doesn't go into like if something happens there, it's just gone.
Right. Great question. So if you needed more blood flow to the brain, which you probably shouldn't, but it will not undergo angiogenesis unless there's a tumor. A tumor, if a tumor can sequester enough pull on its end to ask your body to create a vessel for it, then it will. But you always, that would be cancers, and we kind of talked about that earlier, yes. So and I realized that you weren't here when we discussed that. Skin, blood flow to the skin, we expect that to stay pretty constant unless we're doing some type of activity. And we talked about blood flow to the skin will increase and it will allow us to sweat, release heat, which will help us maintain a temperature homeostasis. So that continues there with the skin. Temperature regulation is carried out by the skin. In the event that blood flow to the skin increases, it warms your skin, causing you to sweat. When you sweat, the sweat evaporates and it pulls the heat from your body. And it mentions that here. The heat radiates from the skin. So also, when it says that sweat causes vasodilation, what's vasodilation? What's happening? The blood vessels are, they're getting bigger. They're dilating, so which means they're allowing for more blood flow. More blood flow will increase the temperature, so it will heat up your skin, and it will allow for that. If your temperature decreases on the flip side, you start to get colder, your blood is shunt from your limbs, and it's kept here in your core, which is why when people are in really cold conditions, they talk about having the frostbite, because your blood will be shunt from these areas. Like pretty much not completely cut off, but minimal blood makes its way to those tissues if you're super cold. Blood flow to the lungs, because it has such a short circuit, and a short distance, it doesn't necessarily have to increase that much if things increase. Okay, so it mentions that here. So since the pathway is short, we don't look at a huge increase in pressure there. Blood flow to the heart. When we're talking about blood flow to the heart, we talk about the coronary vessels. We're not necessarily talking about blood flow through the heart. Okay? So blood flow to the heart, serving the heart, will increase if the heart has to do more work. And it mentions that here as well. Okay, during strenuous exercises, we expect for those coronary vessels to dilate. Coronary vessels are the vessels that serve the heart, and it will continue to increase blood flow to the heart to accommodate for the amount of work the heart has to do. Through the capillaries. Do we want pressure in the capillaries to increase? No, because it could lead to capillary rupturing. So I feel like you understand that. Okay? When we talk about stuff moving through the capillaries, do you remember the difference between lipid-soluble and water-soluble? Fats can get through, proteins cannot. So if it's fat soluble or lipid soluble, it can go right through those vessels. And if it's protein based or water soluble, it has to find a specific pathway. Okay? And that it mentions that here. So moving through those clefts or fenestrations, and these can go directly through those membranes. So here's back in this right picture here is a fenestrated capillary. And I know that because it has multiple openings here, not just the normal clefts. Here showing you the movement through those, so things moving in and out of those capillaries. Circulatory shock. Circulatory shock is any condition in which the blood flow is markedly decreased very rapidly, usually because some type of wound. If you're going through circulatory shock and it can't be restored, your heart can't continue to pump it, you're probably going to do what? Expire, for sure. Okay? Hypovolemic shock is you have lost a whole lot of blood, usually due to some traumatic event. Vascular shock, for whatever reason, your vessels get very dilated. If they get really dilated, that means that they're accommodating more blood flow. But if there's not more blood flow, that means that there's less oxygen exchange taking place. So this sometimes happens, and you see these people fainting or falling over. And of course, we're going to pump them with IV fluids, usually saline solutions, to help increase that blood volume. Cardiogenic shock is where your heart is not efficiently pumping blood. So your heart might be pumping, but it's not cycling the way that it's supposed to. So oxygen rich and oxygen poor aren't making it to its tissues. Eventually your kidney stuff is going to go bad. And I would say before your kidneys, your brain. And so you'll probably expire. Here is all of that, and you got your stab wound, in case you're wondering. Okay, we know the difference between pulmonary circulation and systemic circulation. Pulmonary is through your lungs, systemic is through your entire body, and we talked about that the last lecture, so it goes right, lungs, left, body. The next series of slides that I've moved towards the end are all the vessels in your body. And as we go through them, these are great diagrams when you want to study them, but I'm not going to go through and use each of these to name every single vessel. As we go through them, differences between arteries and veins, I am not going to say, okay, here's this one, what does this serve, what does this serve, what does this serve? I'm not going to do that. These are divided into the arteries it has pictured in red, okay, and it has them labeled. There are many diagrams that just show one side. It's because you need to assume that it's the same on both sides. It helps you with the terminology as far as naming them. At this point, you should be able to figure out a lot of what their location based on their name. Like the pericardial vessels, those are probably serving the heart, the pericardium. Abdominal aorta. Okay, a brachial plexus. Like, it should be something where at this point in our relationship, you should know what's kind of going on, okay? Not necessarily every single one, but you should be familiar with most of them. Gonadal, gonads, which are ovaries and testes, yes, okay? So, you have all of these, and it goes through and it starts to name them: femoral, popliteal. All of these, you hear them, and you should, at this point, have some type of idea where they're located. Okay, there should be very few that you're like, where's that? And this is just showing you the relationship or association of them and how they branch. Okay, so here's just the head and neck, thyrocervical. It's going to be in the neck. Okay, thyro tells you thyroid, yeah, in that cervical area. So in this, yes, like I feel like you can do this. Okay, occipital artery. Yeah, probably very good for the occipital lobe. So here are the arteries that are associated with your brain, and notice how they're on the outside. We talked about in a previous lecture that's the dura mater. The dura mater is surrounding the brain. These vessels are not actually inside of that. Remember, they have the what is that? The aqueducts, cerebrospinal fluid inside of them, that are allowing for oxygen and nutrients to be exchanged within the brain. But this is through the dura mater that you can find all of this, the meninges. Showing you the aorta and then all of the main branching sections. Upper limb. So real quick, this is this, just in a different presentation of data. Okay, here we have that, and the abdominal. Okay. Here, and the leg. Okay, and what you have in one leg should map what's on the other side. And then in blue we have all the veins. Very good. Moving back towards the heart. So that's what how they have all of this discussed here. You're going to see the exact same names, or extremely similar names, to those of the arteries. Okay, gonadal, supraadrenal. These are all the same. It's just whether they're carrying oxygen rich or oxygen poor. And the same setup here. Okay, neck, arms, core. Then we have our leg. Developmental aspects. Overall, you start to develop vessels as you're developing inside your mom, obviously, because by the time you're born, you have to have blood flow throughout. Your heart starts beating around 16 days, so you have to have vessels that are going to circulate that blood throughout your body. Okay, so it mentions here the heart pumps blood by the 4th week of development. So you have vessels early on, even though you're super, super duper small.
Is that different when they say that they're born with their heart beating on one side?
Okay, so it's not different, because if they're born, then that means that their heart was functioning in utero when it was supposed to. And what it's about to reference here is when we talked about the heart, we talked about the shunts, how it had the opening, the foramen ovule, and the ductus arteriosus in between the pulmonary vein, or the pulmonary trunk and the aorta. These holes, because we don't use our lungs in utero, so those holes stay open the entire time we're in utero. And whenever a baby's born, they want that baby to take that first inspiration so that it closes all those holes and inflates the lungs and starts to circulate the blood the way it's supposed to. But if they're born, then the heart had to be functioning. There may be issues, but
I'm saying, like, as far as like how the flow goes, if it's turned
backwards, like while they're in utero.
Is it still connected to the same as far as the trunk and everything? And it's just kind of twisted.
It's not. It's all the same.
Like, what do they mean if it's on the wrong side?
Your heart's on the wrong side.
I've heard.
Say that one more time. What's on the wrong?
Yeah, if you're born with your heart on the wrong side, like where they have to actually physically go in and move it to.
I've heard people being born with the heart outside of their body. Yes. I haven't heard of it being on the wrong side. It is more left, but I haven't heard. I'm sure it's a thing. So I don't want to speak on that because I don't know. But on the outside, we just put a saran wrap around it, and then we.
Just for people calling.
What it is, and they don't know what they're talking about. It would be definitely worth a Google. That's what I always say when people say things. It's worth me Googling it to figure it out. Anyways, right here, these are going to be. We talked about differences in the heart for arteries and veins when we talked about the pulmonary trunk and the aorta, or the pulmonary veins and the pulmonary arteries, not the aorta. Sorry. We're also going to see that same difference where it's reversed in the umbilical artery and vein, but we'll get there when we get to the development chapter, which will be the last one we cover together. And then when you have congenital heart or vascular defects, that's pretty rare. Vascular defects, that's pretty rare. We already know about, when we talk about blood vessels forming, it's going to be if there's a lot of tissue, if there's a lot of oxygen needed for that area, then we're going to see an increase of angiogenesis to support body growth, for wound healing, that could be temporary, to rebuild vessels during menstrual cycles. This is going to be something that we study in the chapter 27 when we talk about the female reproductive system. You have those vessels there, but they regrow every single month because they die every single month if you're not pregnant. continuing with aging, varicose veins we see start to show up, the thinning of the skin, which makes them more obvious, atherosclerosis, which is a buildup, and we do tend to see that there's an increase in blood pressure that usually is associated with less activity and more weight gain with age. All right, that's the end of this chapter, so we'll stop